given a Viva, multiple cases in sequence, followed by feedback at the end. Each candidate will have about 30 minutes time. There will be no break. This is a 2 hour session, might spill slightly beyond 2 hours. So, Shoaib, if you are ready, should we start?
Yeah, yeah, happy to start. Can I start sharing my screen? I think we'll just go straight into it.
Yeah, so I have stopped sharing and you can share your screen, please.
Okay.
Recording in progress.
Okay, can you see my screen?
Yes, sir.
Okay, good. So just a brief intro. So I'm an ST5. I subspecialize in cardiac imaging and nuclear medicine. And today's format's going to be the mock fiver. So we'll just be running through cases. There won't be any PowerPoints or anything. And we have candidate one with us now. So candidate one, can you see this X-ray, this chest X-ray on the screen?
No, sir.
You
Not
can't.
able to see the chest X-ray.
Okay, 1 second. Let me try something else. Okay, here we go. Hopefully you can see that now.
Yeah, we can see it. Over to candidate one, please.
Okay, brilliant. Candidate one, take it away. This is a chest X-ray in a patient who presents with chest pain, upper abdominal pain.
Just
Okay, sir.
just 1 second. Sorry, just 1 second. Shoaib, the image is not filling up whole of the screen. Can something be done about it?
Mm.
If not, then it is fit for purpose, but it would have been better if it was some or the other. It is no. So okay, just continue. Don't worry then.
Okay, that's fine.
Yeah.
Should I start, sir?
Yes, please.
Yes, sir. This is a frontal chest radiograph of a skeletally mature patient who is presented with chest pain and vague upper abdominal pain. Um, I'm just trying to look at both the lung parenchyma. Uh, Not able to visualize anything abnormal in both the lung parenchyma. The chest appears, the cardiac shadow and mediastinum appears normal. I'm trying to look at the bones to look for any abnormality.
Hmm.
Mm, The visualized bones appear grossly normal. Uh, I'm trying to look at the review areas to look for any
Sure.
abnormality. The apex appears normal. Retrocardiac appears normal. The diaphragms appear normal. And trying to look at the soft tissue and the bones in the periphery. Mm,
Okay, what are the review areas?
yes, sir. So there
What,
seems to be some ill-defined opacity in the retrocardiac region.
okay, can you
Your
be more specific?
uh, on the left side, in the retrocardiac region on the left side.
Okay, so what do you think is going on here?
Mm.
Do you want to take control of my screen and then you can point
Uh,
out to me exactly where you think the abnormality is, okay?
yes, sir. Uh, Requesting you for this.
Okay.
Yes, sir. So can you see the monitor? So the mouse. So is this
Okay.
the radio opacity?
So I can't see you actually controlling my screen. Just give me a second.
So is my mouse visible now?
Give me 1 second. Hopefully, okay, try that again. I've just given permission. So take control again. Yeah, there you go. Okay, so where's the opacity? Okay, you think it's there? Okay, fine. So what we'll do is stop there. That's fine. You can give me controls. So this patient went on to have they went away. They came back with some really bad back pain. They came to A&E. So I'll show you another film and let me know what you think. Now tell me, what do you see?
So there is evidence of well-defined opacity in the bilateral spinal region in the mid-thoracic spine. So yeah.
Okay. So is there anything else you'd like to do, or would you like to anything that you'd like to know or do next?
So there also appears to be reduced disk space between the two vertebral bodies. On the basis of this image, the findings are likely suggestive of uh, paraspinal abscesses with pot spine. I would like to inform these findings to the referring physician and also would request for an MRI spine, post-contrast spine for further evaluation.
Okay, that's fine. Let's have a look at the spine as you've said. So what sequence would you like?
So I would like to look at the T2 images actually.
Axial T2.
Yes, sir.
Okay, here you go. You should have control, so please take it away.
So there is evidence of a well-defined soft tissue seen in the pre and paravertebral region in the thoracic spine. There is also evidence of extension of this collection into the anterior epidural space. Uh, the vertebral bodies at these levels also appear affected. So I would like to look at the sagittal images to look at the intervertebral disc.
Yeah, sure. Which sagittal T2
T2
or
sagittal, sir.
okay,
T2 sagittal.
I'll pull up the series, don't worry. Okay, take it away.
So there's evidence of involvement of the vertebral bodies of the mid-thoracic vertebrae as well as involvement of the intervertebral disc with presence of pre-paravertebral soft tissue. There is also extension of the soft tissue into the anterior epidural space. On the basis of these findings are likely suggestive of an infective etiology, pot spine likely. I would like to inform these findings to the referring clinician. The patient also would require isolation probably.
Okay, and just when so I think you're telling me this is an infective process specifically. What do you think is going on?
So it's pot spine, sir.
Okay, so you think this is pot spine. What other sequences would you like to look at when you're normally assessing a spine for an infective process? So we looked at the Sag T2 so far and the axial T2. Is there anything else you'd like to look at?
So we would like to look at the post-contrast images.
Okay, fine. So let's contrast. Sorry, that's pre-con. Here we go. Okay, just does this confirm your suspicion?
I'm not able to.
Are you able to scroll through it?
That's actually moving very fast.
Okay, just stop it there in the middle. I'll
Yeah.
scroll for you. There you go. So does this
Yes, sir.
confirm your diagnosis? Okay,
Yes,
so
sir.
you told me pot spine. What's the underlying etiology? What's the causative mechanism?
Tuberculosis, sir.
Okay,
Tuberculosis.
and how would you differentiate that from a pyogenic infection like a Staph aureus or something?
I'm not sure.
Okay, so if you're thinking this is TB, what tests would you like to do next or consider?
So I would like to request for a percutaneous aspiration of the abscess if possible for confirmation.
Is there anything else you'd like to image?
So I would also like to image chest to look for any abnormalities in the.
So just give it a second, it's going to load, okay? Okay, start scrolling, please.
Yes, sir. So it's not scrolling actually.
Okay, I'll scroll it through for you.
Yes.
So just looking at soft tissue windows first.
Yes, sir. So we're looking at the soft tissue window of the soft tissue window of the chest, post contrast images. Mm. So there is evidence of that pre-paravertebral abscess in the mid-thoracic spine that is visualized on the MRI spine. So I would like to look at the lung window if possible.
Yeah, have a look at the lung windows. Okay.
There's
What
no
do you
evidence of
see?
any obvious abnormality seen in the lungs. So actually, I think there is some opacity in the left lung parenchyma, but the images are getting skipped probably. So I'm not very sure. Like
It's fine, the lungs are clear. So what would you like to do next?
uh, the sputum analysis for acid-fast bacilli, probably.
Okay, fine. So that's the end of this case. We'll move on to the next case, okay? Abdominal X-ray, patient with vague abdominal pain referred by the GP.
Mm. This is an abdominal X-ray of a skeletally mature patient presented with vague abdominal pain. I'm trying to look at the there's no obvious dilatation of any bowel loops. I would like to the domes of the diaphragms are not covered, so it will be difficult if there is any presence of air under diaphragm to comment in this film.
Anything else you notice?
No, sir, not.
Okay, so you look through the notes, the patient has a history of flank pain specifically.
Yeah. There's evidence of some few small calcifications seen in the region of right renal shadow. Yeah. So the mouse is visible.
Yeah, I can see that. That's right. So continue.
This could represent a ureteric calculus with resultant hydronephrosis. I would like to inform these findings to the referring physician and would request for a abdominal sonography to
Okay,
look at.
aside from renal calculi, do you think this pattern of calcification could represent anything else?
This could also that no, sir, not sure. This could be. So I would like to look at the lateral X-ray to differentiate these calculi from gallbladder stones.
That's fine. So we actually have a CT. So the patient presented acutely with. Let me pull that up for you. Okay. Hold on. Scroll through this CT, please.
Yes.
So just focus on what you saw on the abdominal X-ray, just for the purposes of time.
Yes, I'm trying to just stabilize the image.
Sure.
So there's evidence of a small calculus seen in the lower pole of the right kidney out here.
Okay, scroll through the entire right kidney for me.
So yeah, out here. Mhm.
So what do you think is going on?
So the left kidney is smaller in size, the right kidney is bulky in size.
With regards to those calcifications you saw, what do you think how would you describe that?
So the calcifications are looking like nephrocalcinosis. So they're present in the medullary region.
Okay, yeah, you can stop scrolling. That's fine. So what's your differential diagnosis?
So there's evidence of calcifications in the medullary region of the right kidney that represents nephrocalcinosis.
What could cause that?
It could be because of I'm not
That's
recollecting
fine.
it.
Okay, that's fine. That's the end of this case. Let's move on to the next case. Is the image bigger if you see it like this, or if I make it full screen, just so I know? Is that more clearer to you?
Yes, sir.
Okay, fine. Chest X-ray in a young gentleman, 25 years old, comes in with a sore throat and fever.
So, so this is the frontal chest radiograph of a skeletally mature patient. Trying to look at all this things systematically. I'm trying to look at both the lung parenchyma initially. Both the lung parenchyma appear appear normal. So the image is actually blurred out. I don't know if it is the
It's blurred.
yes, sir, somewhat blurred. So now it's better.
Okay, continue.
There's evidence of retrocardiac opacity.
Okay, that's fine. I think that's normal. Let me invert it. Does that help you?
Yes, sir. So there's evidence of so the right hila appears slightly bulky. There's also evidence of reticular opacity seen in the right lower zone out here, sir.
Okay, fine. So this patient presents with worsening fever, terrible inflammatory markers. What would you like to do next?
I would like to do a CT chest for further
Okay,
investigation.
yeah, so they had a sore throat as well, so we did a neck and chest, and I'll bring that up for you. So look at the neck first for me, please, and let me just zoom into it first so you can see it nice and clearly. You should be able to scroll through that, please.
Yes, sir. Sir, I'm looking at the chest images, post-contrast images. So there is evidence of a well-defined peripherally enhancing abscess seen in the left tonsillar region. Sir, out here. Sir, out here.
Sorry?
So there's a well-defined abscess, tonsillar abscess, left-sided.
Yeah, continue.
I'm trying to look for any lymphadenopathy. Uh,
Candidate one, are you still with us?
uh, I think, okay. So there's evidence of air fluid levels seen in the both
Okay,
the
we'll come on to the
bronchi.
thorax in a second. Just focus on the neck. So what have you seen in the neck so far?
So there's evidence of left tonsillar abscess.
Anything else?
Mm. So there are a few nodules in the right lobe of thyroid also.
That's fine.
But
Okay, let me bring up the thorax for you. So you can look through the thorax. I'll put it on lung window for you.
yes, sir.
So scroll through the thorax for me, please.
So there's evidence of multiple peripheral areas of subsegmental consolidation seen in both the lower lobes. There is also evidence of left-sided pleural effusion, uh, bilateral pleural effusion.
So what do you think is going on?
So based on these findings are likely suggestive of an infective etiology, likely viral, probably.
Okay. So in view of, think about, try and tie it together. What did you see in the neck?
So there was a left tonsillar abscess.
Is there anything you'd like to go and look back on at the neck?
Mm, mm, Not sure.
So
So can I
review the
check
blood,
it?
review the vasculature for me in the neck, please.
Yes, sir.
Is there anything you notice?
So left IJV is not visualized. So could
Okay.
be compressed
Or,
and could be thrombosed.
okay.
So there's
So
a
now,
possibility
now,
of
now
left
knowing that,
side.
can you put that together?
So there's a possibility of left-sided IJV thrombosis because of the left tonsillar abscess. So there's extension of the left tonsillar abscess posteriorly into the carotid space.
Okay, I'm putting all of this together. Do you know what this syndrome or disease would be called?
Uh,
Okay, let's stop there. That's fine. Thank you. Thanks,
Ludwig's
Candid.
angina.
Sorry?
So Ludwig's angina.
That's fine. We'll come back to that. Okay, I think it's been about 20 minutes. Let's stop there. I want to give you some feedback, candidate one. Okay, it's very good. There's some tricky cases, but I think you handled them well. So let's just go through them for the purposes of yourself and everyone else. So this X-ray that I showed you, hopefully you can see the X-ray, yes?
Yes, sir.
So I think now you can, obviously you've seen the thoracic spine X-ray, but you can appreciate there's a paravertebral, there's widening of the paravertebral stripes bilaterally. So this needs to, it's subtle, but it's there and it needs to make you think there's a paravertebral abscess. So ideally, you want to be picking that up on the first film. You don't want to wait for me to show you the thoracic spine X-ray where it becomes a bit more obvious. I think with you keep getting distracted by retrocardiac opacities because you said it in this X-ray and another X-ray, but just get used to looking at, what normal retrocardiac density looks like. But the abnormality here is along the paravertebral stripes. The rest of the chest X-ray is normal. So at this point, you wouldn't even request a thoracic spine X-ray. You would just go straight to one thing you needed to do more was ask about the history, ask about the blood tests. Because if I said that this person had been traveling, or I said that he's got raised inflammatory markers or whatever, that may have guided you a bit more. So at this point, as you rightly did, you asked for an MRI spine, which was very good. And I think now the diagnosis becomes obvious. So you asked for a Sag T2, which I think is a reasonable place to start, or alternatively a stir, because a stir would tends to just highlight the pathology. But what's going on here? There's a few things that I know it's hard and it's a vibe and you're trying to be quick, but there's a few things that we need to pick up on. So firstly, um, this is T8, T9. You don't need to necessarily say the thoracic level because you haven't got much time. You can just say lower thoracic spine if you wish. But there's actually slight depression of the superior end plate of T8 here. So there's a pathological fracture there, okay? That's the first point. The second point is the infection is intraosseous spreading into the disc space. So it's an intraosseous abscess spreading into the disc space, the epidural space, the paravertebral space, and the paraspinal musculature. I would always advise looking at a post-contrast image when you're thinking of spondylodiscitis. So let me just find that for you. So here you can see that the abscess is extensive. It extends into the paravertebral space. There's an epidural component as well, which you rightly mentioned, is also involving the left rib. So these are a few things that you didn't mention. That is involving the ribs, the superior end plate depression fracture, and also mention that although it's extending into the spinal canal, there's no actual cord compression because, of course, that's very important, right? So there is narrowing, but I wouldn't say there's definite cord compression there. Then we had the CT thorax, and this doesn't really add much. Just shows you there's nothing grossly abnormal in the lung parenchyma. And again, we can just visualize the actual paravertebral collection. So what I wanted to push you to say is that, okay, you said it was Pott's disease, but you didn't justify to me why you think it's TB versus a pyogenic infection. So I think it's hard to say definitively on imaging, but a few of the giveaways are TB affects the thoracic spine. It tends to affect the thoracic spine. And in TB, the discs spaces tend to be relatively preserved, whereas in pyogenic infections, you get more infection centered upon the disc. But again, these are soft signs. The extensive paravertebral collections and paraspinal collections you tend to get in TB in comparison to pyogenic infection. But yeah, you rightly said then, you'd go on to do sputum testing, blood tests, etc., which is what I wanted to push you towards. But that was case one. Did you have any questions?
No, sir.
Okay.
Yes.
Good. And that's fine. Let's go into case two. So I think now looking at this film, you can appreciate there's some speckled calcification involving the distribution of the right kidney.
Yes,
And the
sir.
rest of the film's normal, yeah. I would say I think when people look at abdo X-rays, you can fall into the trap of just looking at bowel. But remember, there's more to an abdo X-ray than bowel, and particularly in TB, that they may throw in these little cases which are subtle, but they're definitely there.
Okay, sir.
Then we had the CT, and I think you rightly picked up, and is what I wanted to push you towards. This isn't just renal calculi. This is a ureteric calculus. Sorry, this is a medullary nephrocalcinosis. And the differential for that is something that you should learn for your 2B because it could definitely come up. And I always say have 3 differentials for every case. So medullary nephrocalcinosis, you're thinking of parathyroid disease, so hyperparathyroidism, medullary sponge kidney, or renal tubular acidosis. Okay, so just have a few things off the tip of your tongue that you can roll off. And the key thing is none of these stones are actually in the calyces, they're actually centered upon the medulla, and that's how we know it's medullary calcinosis. Okay,
Yes,
do you have any questions about that case?
no, sir. That was a nice case, sir.
Okay, that's fine. And then finally, this case, this chest X-ray is very hard. You could actually say it's normal, but there's perhaps some subtle nodularity within the right upper zone here. So if I invert it, you can kind of see there's some speckled nodularity here. This patient had sore throat, and we ended up doing the CT, as I said. And I wanted you to pick this up when looking at the neck, but there was an IJV thrombus, which you picked up later. And it was extending into the sigmoid sinus, as you rightly picked up, which was very good. But whenever you're looking at a tonsillar abscess or a neck collection, what sort of things are you thinking of? What do you need to look at? So I'm asking you, candidate one.
So we need to look at all the vessels also.
Yeah,
And
so
if
vessels.
and if
So
there is
what's
any pharyngeal extension of the abscess.
exactly? Yeah, really good. So you want to look at the collections. So in my mind, when I'm looking at CT neck and I see the collection, so there's a collection. The next thing I'm going to look at is the airway, because the airway is the first thing that will kill the patient. So the airway is patent, and you must mention that. So there's a left paratonsillar abscess. The airway is patent. The next thing I'm going to look at are the blood vessels, because you know, they're also very important, and pathology of the blood vessels could be lethal. So you can see there's asymmetry. You've got two vessels here, one vessel here. There's an IJV thrombus. It extends all the way up to the sigmoid sinus, and it extends down to, you know, quite far inferiorly there. So they've got a combination of a collection and an IJV thrombus. The thing you must mention is there any retropharyngeal involvement or danger space involvement? So on CT, you can't tell the difference between danger space and retropharyngeal collections. But the point is, if there's anything which is just in front of the cervical spine, you need to raise that, as that can extend down into the mediastinum and cause mediastinitis. So that's an important thing for you to mention. There's no retropharyngeal or danger space involvement, and there's no evidence of mediastinitis. And then we looked at the thorax and we saw peripheral wedge-shaped consolidation, right?
Yes, sir.
So this is called Lemierre syndrome. So go look it up. But basically, you get thrombophlebitis of your internal jugular vein, and you get septic emboli. So these are yet to cavitate, but if we image them later, these will probably be cavitating foci. And that little right upper zone speckled nodularity we were seeing on the chest X-ray probably what represents this tiny focus of consolidation here. So these are, yeah, likely septic emboli, even though they're yet to cavitate. And just for the chat to keep you involved, what's the causative organism in Lemierre syndrome? Because these are the sort of questions they'll ask in your Viva to push you once you're doing well and they've picked up that you know what's going on. They'll push you with a few more questions. So yeah, as you've all rightly said, Fusobacterium necrophorium is by far the most common, and you'll get a thrombophlebitis and septic emboli. Good. Can we have candidate 2, please?
Yes, sir.
Hello, candidate 2. Just give me 1 second. I'm going to load up the next case.
Take your time. Thank you.
Okay, candidate 2, whenever you're ready, I'm going to start your time. This is a middle finger X-ray. Patient who presents with atraumatic finger pain.
Okay, so this is a frontal view focused on the left middle finger, showing some destruction involving the middle phalanx with thinning of the cortex. The pattern of destruction appears to be permeative in nature, in appearance, sorry. Some cortical thinning or scalloping. There might be some medullary expansion. There is adjacent increased density in the surrounding soft tissue, maybe probably due to edema. No periosteal reaction, no cortical breakage. Could you tell me the history again, please?
It's just presentation to A&E with atraumatic pain.
Okay, so I'm suspecting an infectious process versus an aggressive bony lesion. So I need to further investigate this patient.
Okay, so do you think this is aggressive or benign?
It is aggressive in nature, so it can be either infection or an aggressive bony lesion.
Okay, what makes you say it's what makes you say it's aggressive versus benign?
Because of the permeative pattern of the destruction or the lytic lesion, also the surrounding soft tissue involvement.
Okay. So if I asked you, how do you describe the transition zone of this? What we think
Wide transition zone. It's not narrow.
okay.
Involved.
Can you think of any benign lesions which might look like this?
Yeah, in chondroma.
Okay. So do you want to reconsider your description?
Yes, I would because there are some punctate calcifications within the distracted area, which could represent soft tissue calcifications from behind the bone or within the lesion.
Okay. So if
So,
I tell you this is benign, is there anything else it could be?
chordoma.
How would you describe the pattern within the medulla?
I said, I think it's permeative.
Okay. Anything else?
I would recommend MRI.
Okay, that's fine. We don't have that available, but actually they happen to have a chest X-ray, which you might find could guide you. This is done on the same day.
Okay. So
So
this is a
describe what's happening on this chest X-ray.
so this is a frontal chest X-ray showing a marked hilar enlargement, probably due to bilateral lymphadenopathy with involvement of both hilar groups and the right paratracheal group. This pattern is characteristic of scleroderma. So I think sarcoidosis, sorry. So I think the skeletal manifestation shown before would be also a manifestation of scleroderma, which could cause this lacy appearance with bony expansion.
Okay, you said scleroderma. I think you mean sarcoidosis, right?
Yeah, sarcoidosis. I said yes. I said sarcoidosis thereafter. Yes.
Okay, how would you describe this pattern of lymphadenopathy?
Yes, as I said, bilateral hilar and right paratracheal lymphadenopathy.
Okay, what would you like to do next?
I would do. Okay, so this is sarcoidosis. Um, uh, I think we need a biopsy from the lymph nodes in the bronchial.
Okay, before that?
Before that, laboratory tests, ACE.
Yeah, in terms of imaging, what imaging would you like to do next?
Chest CT scan.
Okay, so here's the chest CT. So if you take control, you should be able to scroll.
Okay, I will try. This is my first time, but so I'm not sure about the technical aspects. Okay. I'm sorry, sir. I'm not in control yet.
That's okay. Okay, no problem. Look, if you're struggling, I'll scroll for you.
Yes, thank you.
Okay. So we'll look at soft tissue windows first, okay?
Yeah, thank you.
So tell me, what do you see?
So, as said, when reporting the X-ray, bilateral hilar soft tissue densities, probably enlarged lymph nodes, right paratracheal, carinal as well. I think I saw some carinal lymph nodes. I need to check also the lung window to see any. Okay, so para-aortic as well. Okay, yeah,
Okay,
lung
that's fine. Have a look at the
window.
lung window. That's fine. There's
Yes,
lymphadenopathy.
you have to
Look
see
at the
any
lung window.
manifestations. Yes. Okay.
Okay, so tell me
Okay.
what's going on.
Yes. So multiple paraseptal emphysematous changes, mainly in the lung apices. Also, there are multiple nodules, variable in size. Um, I'm trying to see if there are any other nodules and determine their pattern. Okay, so mainly perilymphatic, I think. Um, okay, there are some areas of interlobular septal thickening, some areas of emphysematous changes. I don't know if this is emphysematous or cystic changes. I'm trying to determine. So cystic changes, not emphysematous changes. no bronchiectasis, some ground glass opacities bibasally.
Okay, so summarize what's going on.
I think this is a pattern of non-specific interstitial pneumonitis,
Okay.
but I'm not quite sure.
So do you think the lung changes are related to what you described earlier?
I think there are two pathologies. Maybe the paraseptal emphysematous changes are not related. The nodules, I'm not quite sure. I think sarcoidosis causes tiny nodules, but not this size. And those nodules look speculated. Some of them look speculated.
Okay, so
So
what would you like to do
maybe a
next?
combined pathology.
So what would you like to do next?
Okay. Okay. I will start by confirming sarcoidosis.
Yeah,
Mm, dif-
that's fine.
not
Let's stop
quite
there.
sure.
We're going to move
Yeah.
on to the next case, okay?
Okay.
So here we have a patient who presents to A&E with abdominal pain, okay?
Okay.
So if you can't scroll, I'll scroll for you.
Yeah, thank you.
Okay, start talking.
So this is a contrasted abdomen and pelvis CT scan, axial cuts in the portovenous phase. Okay. Uh, Currently, we are at the level of the upper abdomen. I'm trying to see where is the abnormality. Uh, can you focus on the right upper quadrant, please? Yes, this region. Okay, so the liver is unremarkable. The gallbladder also is normal. Uh, okay. No features of intestinal obstruction, no pneumoperitoneum, no free fluid. Okay, the vessels are patent, no atheromatous changes. Okay, no areas of fat stranding, but I see some bowel anterior to the IVC. I'm not quite sure this is okay. So I need to check the size of the small and large bowel, please. So one more scroll, please. So yes, most of the all of the small bowel is at the right side. The large bowel is on the left side of the abdomen. So I need to check other features of non-rotation, malrotation, SMV and SMA. Okay, so the SMV is more to the left. Okay, when you go down, yes, here. Okay, so there is non-rotation. The duodenum is not going to the retroperitoneal region.
Okay, so tell me, what do you
So
think is going on?
yeah, so this is non-rotation, but I don't see features of intestinal obstruction.
And so just summarize, how do you know this is malrotation?
Yeah, so the small bowel are entirely at the right side, the large bowel is entirely at the left side. The superior mesenteric vein is to the left of the superior mesenteric artery. The duodenum is not going its normal course, it's not going to the retroperitoneal
Okay,
region,
fine.
it stays at the
Yeah,
right.
so what landmarks do you look for in malrotation specifically?
Mainly, I look for the superior mesenteric artery.
Anything else?
I look at the duodenum. I look at the small and large bowel.
What part of the duodenum do you look at?
I look at the third part.
Okay, and fine. Okay, and anywhere else in the bowel that you might look at?
Um, Anywhere else?
Show me where is the
Yes, the ascending and descending should be retroperitoneal. Maybe the ascending here is not. So
where's the
let's
cecum?
the cecum. Yes, it's near the midline. So it's not in the right retroperitoneal region. Sorry, the ascending. Yeah.
Okay, fine. So this patient's come to A&E with crampy on and off abdominal pain. What would you like to do next?
Crampy on and off abdominal pain. Okay, so maybe follow through study to confirm that if there's any partial obstruction or low grade obstruction. I'm not sure.
Okay, fine. Let's move on to the next case.
Okay.
So this is a frontal radiograph of a 80-year-old lady who just presents generally unwell to the emergency department.
Okay, so frontal chest X-ray showing an obesity within the right lower zone. It's not silhouetting the right hemidiaphragm or the right cardiac border. There's obliteration of the right costophrenic angle, which probably related to effusion. Okay, so my impression would be pneumonia with paraneumonic effusion. I don't see any sign of volume loss. The left costophrenic angle is clear. Maybe there are other consolidations. Maybe there is a suspicious one within the left upper zone.
Where?
Yes, here it is.
Yeah.
Yes.
Okay, fine.
Yes.
Okay, so you've told, is there anything else you've seen?
Lymphadenopathy, maybe at the right hilum is not well demarcated, so I couldn't tell for sure if there is lymphadenopathy or not. Okay. There are some clips in the right axilla. Okay, so maybe she had breast surgery or a case of breast cancer. So I would be more suspicious of metastasis, especially regarding the few
Can
foci or few
you
nodules.
see
Yes.
any evidence of metastasis?
I would, yes, the few lung focal obesities would suggest a metastasis until proven otherwise, especially in this case.
And what do you think of the
I would look at the bone to
Yeah, what do you
confirm
think
if
of the
there's any, yeah, bony lesions. The ribs, I think they are clear at the left side, the right side uh, clear as well and remarkable. The spine is not well visualized, but I don't see any frank lesions. The clavicles, scapula,
Okay,
shoulders, I
that's
don't
fine.
see any.
What
Yeah,
would you like to do next?
I would go for chest CT with contrast.
Okay. Just
Uh,
give it a second to load.
okay, so this is chest CT scan, lung window contrasted. Okay. So multiple speculated obesities, mainly within the largest so far is within the left upper lobe. Okay, but there are multiple in random distribution, upper lobes as well, variable in size. So I'm suspecting metastasis. I want to check the right lower zone obesity, which was seen on X-ray. Extensive obesity in peribronchial or peribronchovascular distribution. I suspect lymphangitis carcinomatosis. Also, there is a right-sided pleural effusion.
Okay. Is there anything else you'd like to look at in the thorax?
The bone, and the hilum, the soft tissue, and
So
the hilum and the upper abdomen and upper lower neck. Yes.
let's just focus on the thorax.
Okay. So multiple bony lesions, vertebral, and within the ribs, suggesting metastasis. Also, the liver, there's a large lesion within the
Yeah, don't
liver.
worry about it. Yeah, I agree, but let's focus
Yes.
on the thorax.
Yes.
Okay, and then we'll look at the look at the mediastinum.
Mediastinum, yes. Okay, multiple lymph nodes. Okay, mainly within the hilar region. I think they are bilateral.
So summarize to me what you think is going on here.
So this is a case of metastatic breast carcinoma with involvement of the lung, lymph nodes, bone, liver as well, with lymphangitis carcinomatosis
Okay, what makes you
and
say it's breast cancer?
malignant right-sided pleural effusion.
What makes you say it's breast cancer?
Because of the multiple metallic clips at the region of the breast and right axilla.
Okay.
Also, the pattern of uh, the lytic lesion. I don't think I see mixed lytic and sclerotic. I think mostly are lytic lesions. So I need to correlate with the clinical history.
Okay, fine. Let's move on to the next case. Actually, we'll just do running a little bit short, so we'll just do a quick case. Let's do this one. Okay. Take me through this ultrasound. So this is a abdominal ultrasound for a young lady. She presents with obstructive LFTs. Okay.
Okay, so uh, mul-
So don't worry about the kidney. Just focus on.
okay, the liver.
Okay. So those are all the images, and is anything you've noticed
Okay,
so far?
okay, so yes,
Okay, go on.
okay.
Start presenting.
Okay, so this is an abdominal ultrasound showing a well-defined hypoechoic lesion within the epigastric region. It is not showing any evidence of internal vascularity, no calcifications. Uh, okay, no surrounding inflammatory changes. No associated biliary dilatation. The common bile duct is normal, and also as well as the intrahepatic ducts. It measures about 6.6 by 3.3 centimeters.
Okay, so
Um,
we're looking. This is the gallbladder. Okay, so what do you think about the
uh,
gallbladder?
okay, so the gallbladder is filled with um, uh, slightly hypoechoic material. I think they might be sludge. It's not dilated. Its wall is not well visualized, but I don't think it's thickened. Its ecogicity is almost similar, close to the liver. So um, she might have hepatitis.
Okay. And remember, I said she's got obstructive LFT. So what would you like to do next?
Okay, so um, okay. In the ultrasound, I would add as well if there's any periportal lymph nodes, if the liver is it's not hypoechoic, no periportal edema.
No.
Um,
But just in terms of,
okay.
is there anything, she's got obstructive LFTs and you've seen this on ultrasound. Is there anything you'd like to do next?
Okay. Um, I'm not sure.
Okay, fine. So we do further imaging and we do a MRCP, okay?
Okay.
Uh, is there a particular sequence you'd like to look at?
Yeah, the axial T2 first.
I can see a T2. Okay, so we have a T2 haste, which we can look at.
Mhm.
Yeah, just start presenting.
Yeah. Okay. Uh, okay, so there is an abnormal linear intensity within the gallbladder. Uh, is there any heavy T2 sequence?
Good question. Let's see what we have. This is just another haste. We've got the thick slices. That's all we have. All I have is just a normal T2 haste.
Okay,
And
so
I think I have a trophy as well, but yeah.
I want to make sure that there are no filling defects within the biliary tree. Okay, so the biliary tree is unremarkable, both intra and extrahepatic. Um, could this be a parasite residing within the gallbladder?
Are you, what makes you say that?
The the shape of the intensity.
Okay.
I don't see any surrounding inflammatory changes around the gallbladder, so uh, it's not gravity dependent, so it doesn't look typically like a sludge.
Is anything
So,
okay? So if you're thinking that's the diagnosis, what would you like to do next?
mm, um, okay, I'm not sure.
Okay,
Sorry.
fine. No problem, Kennedy. Let's stop there, yeah? Let's go through your cases. So very well done. You had a good, definitely good stab at all of those. I think we started with this one. So this is a difficult case, but I think what you in any this is for the whole audience and for you as well, candidate. But for any bone lesion, you need to quickly decide, is it benign or is it malignant? And I think you went down the malignant route quite quickly. And whereas actually, if you look at that, and if it looks a bit like an enchondroma, right? Obviously, we know this is sarcoidosis now. If you said this was an enchondroma, I don't think that's a reasonable differential to have here. This is a lytic bone lesion. So the way I would describe it, this is a lytic bone lesion with a narrow zone of transition. There's no cortical destruction. There's some mild soft tissue swelling. There's perhaps a lace-like appearance to the medulla, and that's it. I would leave it at that. I think you started using words like destruction quite early on, which pushes one down the malignant pathway. This is not malignant. This is benign, right? You can kind of trace the outline of the lesion. It's just filling the whole middle phalanx there. We also had a lateral, which I don't know if that would have been helpful to you, but there was a lateral. And again, you can kind of see it's well encased within the bone. It's not destroying the bone. It's not got a wide zone of transition. So this is a benign bone lesion. I think to call this sarcoidosis from the off is probably a bit of a stretch, but you could definitely say that there's a lace-like pattern there. And a lace-like pattern or a honeycomb pattern, that equals sarcoidosis, whereas an enchondroma, you can get like speckled calcification or a chondroid matrix. But basically, what I wanted you to get at is this is a benign bone lesion, and that's how I would present it when pitched with this in the exam. Then obviously, once you get the chest X-ray, it becomes a bit more straightforward, right? So you very rightly picked up on there's widening of the right paratracheal stripe and bulky lobulated contour to both hilar. So this is called the 1-2-3 pattern of lymphadenopathy. 1 being paratracheal, 2 and 3 being hilar, and it's commonly seen in sarcoidosis. The rest of the lungs appear relatively unremarkable. There's perhaps a patch of airspace opacification at the right lower zone there. But in essence, the key finding here is the lymphadenopathy, which you did well to pick up on. And then we had the CT thorax. So I think you got a bit confused here. So this is all sarcoidosis. I think you went down the path of a dual pathology. So lymphadenopathy, I think that's quite obvious, isn't it? So we can see the paratracheal and the mediastinal and the high lymphadenopathy there. It's bulky, it's obvious. But then when we look at the lungs, these are essentially interstitial changes which are compatible with sarcoidosis. So you have a few nodules, nothing extensive. There's no particular perifacial nodules which you'd expect in sarcoidosis or subpleural. You could say, yes, these are perilymphatic, but there's not many nodules. So there's a few nodules, and then you have at the hilar, you have these kind of like perihilar ground glass opacification and linear densities which are extending out to the peripheries of the lungs with some perhaps mild tractional dilatation of the airways. So this is just all interstitial lung disease relating to the patient's sarcoidosis. And it's particularly prominent around the hilar. There's relative sparing of the lung bases. So as you know, in sarcoidosis, it typically affects the mid zone, the upper zones. There's relative sparing of the bases. It's not a completely typical pattern, I agree, which is why I understand you got confused. But this is essentially pulmonary sarcoidosis. Okay. And then always, as you alluded to, but always offer the blood. So, I'm going to do a serum ACE. I'm going to check a bone profile and check for the patient's calcium. I would like to, and this is one thing people always forget, is I would always like to look at the previous chest radiograph to see what that looked like, because obviously that gives you an idea of stability of disease. And then, yes, if you're still confused, you can consider an EBUS and sampling of the lymph nodes. But start off with the basics. So calcium, serum ACE. Do you have any questions on that?
No, thank you, sir.
Okay, good. And if anyone in the chat has any questions, you can post them in the chat. I am keeping an eye on it. So I think you picked up on this pretty quickly, which is good. It's gut malrotation, intestinal malrotation. The key giveaway is, and what I was trying to push you for, is you look for the DJ flexure. That's one landmark, and the other landmark is the cecum. And then the other thing is the SMA and the SMV. So you very quickly picked up on, yes, the jejunum is all on the right here, and the large bowel is on the left largely, and then we have a medialized cecum. So this is gut or intestinal malrotation, sorry. And if you actually follow, I know it's difficult because I was scrolling, but you don't actually see the duodenum crossing the midline, which is what you'd expect in a normal patient. But in this patient, if you follow this bit of loop, this bowel, small bowel here doesn't actually cross, there's no small bowel crossing the midline. So this is probably a bit of the distal duodenum here. It doesn't ever cross the midline. And then the cecum is this thing here, and you can see the terminal ileum coming into it. So it's all medialized, which is abnormal. And then finally, you look at the SMV and the SMA. Sorry, the SMV, SMA there. So the SMV is to the left of the SMA, which is, again, not what we'd expect. So this is intestinal malrotation. And in terms of what you do next, that this is not an acute presentation. This is the patient's coming with crampy on and off abdominal pain. He's not obstructed, which is what you rightly said. So this doesn't need urgent investigation, but it does need a surgical referral and an MDM discussion as to what they're going to do next. That's what I was trying to push you for. Okay, this case. So this is a difficult radiograph, but actually there's some very important findings on it, which if you look closely, you can actually see them. So absolutely right pleural effusion, right basal consolidation, but then you can actually see them scattered nodules. So, there's a nodule here, some nodularity over here, and you can see the more you look, the more nodules you start to see. There's one here, 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 and maybe if you invert it, it's a bit clearer, right? Even this thing here, it might be an endon vessel, might be a bulky met, and it probably is from what we saw in the CT. So there's all this nodularity, which doesn't make sense for just infection in it. And if you look at this radiograph, they've got right-sided surgical clips. So this patient's probably had a mastectomy from this radiograph, right? So previous cancer, nodules in the lung, that's always a concerning finding. And if you look closely at the bones, candidate 2, can you see that the left fourth rib is missing?
Yes.
Yeah, so there's asymmetry. You can see the rib on this side. So when I'm looking at ribs, you can almost just follow them around. So there's a rib here, but there's no rib here. There's a rib here, and there's a rib here. There's a rib here, and there's a rib here, but there's no rib here. And it's difficult because it's at the lung apex where there's a lot going on, but there's definite absence of a rib there. And I don't think you could call that projectional because you can see the rib and then it just ends. And it ends here where there's lung. So there's not even any bone overlying it or anything. It's just ends. So that's a bone metastasis. So you need to raise malignancy in this case. And I think once you get onto the CT, it's quite clear that they've got malignancy. And whenever you're doing these exams, try and volunteer as much information as possible. I want you to tell me what the diagnosis is. I don't want to ask you what do you think the primary is, okay? Because that will help you get the higher marks. So you can see they've got a right-sided mastectomy. So I'd present this obviously this is a post-contrast CT thorax. The patient has multiple scattered lung nodules in a random distribution with some associated mild interlobular septal thickening. There's a right pleural effusion and overlying consolidation. Of note, there are multiple predominantly lytic destructive bone lesions, the largest affecting the left fourth rib. Putting this together and given the previous history of mastectomy, I suspect this is metastatic breast cancer. Next, I would like to do completion imaging of the abdomen and pelvis and refer this patient to the breast clinic for urgent assessment and MDM discussion. So you should volunteer all of that information. Don't wait for me to ask you, okay? And what I would advise is don't spend too long describing everything that's going on. So I think you would kind of be very descriptive. So just say there's multiple scattered lung nodules. That's it. Okay, whether they're spiculated or rounded, I think it's irrelevant. These are obviously lung metastases, right? But otherwise, it was very good. I think that was the end of that case. Do you have any questions on that case?
No, thank you.
Good. And then we did this case. So this was it's always tricky when if I'm scrolling through, but so this is an abdominal ultrasound, and the gallbladder here is just complete. You know it's a gallbladder because it's labeled, right? So that makes it a little bit easier. But the gallbladder is full of gunk, basically, hypoechoic material admixed with some hyperechoic linear material. It's indeterminate as to what that is. There's no biliary tree dilatation, so this could be sludge. But because she's got obstructive LFTs, we need to investigate this further, right? We can't just leave this. So that's what I was trying to push you for. The other thing is, I think you mentioned that something about hepatitis on the ultrasound, but I'm not sure what you were referring to. The liver's basically normal. It might look a bit hyperechoic, but other than that, it's a normal liver. And then when we look at the MRCP, you very rightly picked up on there's no biliary tree dilatation, which is super important because she's got obstructive LFT. So yeah, that's a good thing that you said. So these are tubular or linear hyperintensities within the gallbladder lumen. Does anyone know what these could be? Yeah, so parasites, I agree. Anything specific? Yeah, well done. So someone said it, a couple of you said it, Ascaris. So Ascaris lumbricoides, you can get these biliary worms, and they can live in your gallbladder, and that's what this represents. There's no biliary tree dilatation. We had some diffusion weighted imaging. They don't restrict, so you're not thinking that this is some weird cancer or something else going on. But this is a parasite infection, and these are biliary worms or Ascaris. Good. And is that all? That's all the cases we did, isn't it?
Yes, sir.
Okay, well done, candidate 2. That was very good. And if we can get candidate 3, please.
Thank you for the tips and your effort. Thank you.
No worries.
Yes, sir, I'm here.
Okay, good. So I'm just going to load up your case. So bear with me 1 second. Oh, sorry, someone's just before we start, there's a couple of questions in the chat, which I'll quickly take now. So what would you do next in the biliary worm case? So you would refer them to a upper GI MDM, and they need an ERCP, basically, okay? So they can endoscopically remove them. In general, in any biliary tree pathology, if you're pushed as to what to do next and you're not sure, ERCP is not a bad idea, because then you can actually explore the biliary tree sample if you need to. And then let's just see if there's any other questions. Okay. Good. That's it. So candidate 3, are you able to take control of my screen?
Okay.
Because I think it's much easier. If you're able to scroll, it makes things easier.
Okay. So I request.
Yeah. Okay, you should have control.
Okay.
So let me give you the history. So I'm going to start your time. We have 30 minutes. This is a patient who presents with an out of hospital cardiac arrest.
Cardiac arrest.
Yeah, cardiac arrest. So they've come to A&E in an ambulance.
Okay, I've been provided with axial cuts of CT with contrast chest for an adult patient come with cardiac arrest. Just I will scroll and then I will comment. This is chest and abdomen. Sorry, upper abdomen only. Okay. So I can see that both pulmonary artery appearing with no any opacification. Just I think that there is increase in the interventricular septum of the heart, increased thickness, and also the wall of the right ventricle. I think it's increased.
Okay.
I want to check the coronary vessels also. Sorry. The right coronary appearing normal. The left coronary, I couldn't see exactly the left coronary artery.
Okay. And point to me where the right coronary artery is, please.
Okay, just 1 second. This one.
Okay, that's fine. Follow it.
Okay. Sorry. It's giving the branch.
That's fine.
But
So what do you think of it?
Just 1 second. I couldn't see it with this. Maybe there is a thrombosis within it.
Okay, that's fine. Tell me more about what you think of the ventricles.
The ventricles, the wall of the right ventricle and the interventricular septums appearing increase in the thickness. Maybe there is evidence of cardiomyopathy.
Okay. Is there anything else you think this could be?
Let me just try to look. No, I couldn't really appreciate anything more than this.
In terms of the
I
ventricular
couldn't
thickening.
find the left coronary artery. I couldn't
That's
trace.
fine. Don't worry about the left coronary. In terms of the ventricular thickening, is there anything you think that this could be other than cardiomyopathy?
Just no. Nothing come to mind with other than this.
Okay, so what would you like to do next?
For this, we can do a cardiac MRI for.
Okay, that's fine. We have an MRI here.
Just yeah.
So I'll scroll through this one for you. So this is like the CNA loop, 4-chamber CNA loop. Okay.
Okay, so the MRI confirms the diagnosis of confirms that there is marked thickening of the interventricular septum and also the wall of the right ventricle with decreased cavity of it. Just I want to check the other. Okay,
This is
this is dark blood image for the cardiac. I couldn't see just 1 second. It would be the same, the wall of the right ventricle, the interventricular septum,
So what do you
So
think is going on?
there is no delayed enhancement or something.
We don't have
Just
those images. Don't worry about that. And just in terms of focusing on the ventricular wall, what do you think is going on?
okay. So if there is, I couldn't. There is no segmentization of the interventricular septum, just only thickening. I couldn't see abnormal signal within it, so it's not arrhythmogenic. I really don't know exactly what should I think about if it's not cardiomyopathy.
Okay. At what points in terms of the cardiac chambers, are they dilated or normal in size?
No, it's not dilated, it's a hypertrophic.
Okay. And you're telling me it's just the right ventricle. So other than a
Right ventricle,
cardiomyopathy,
interventricular septum. Yes,
okay,
right.
if I tell you the interventricular septum is normal, is there anything else you can think of?
So I can see just so it's a hypertrophy if the interventricular septum is normal. So I think the wall of both ventricles is slightly increased in size, and the cavity of both ventricles decreased.
Okay, so the patient has an echocardiogram and it shows nodular, grossly thickened right ventricular myocardium, but the left ventricle is normal.
Okay, this would be not arrhythmogenic, but just it would be increase the compactions or something. I don't know exactly for the right ventricle only. Yes, I.
Okay, that's fine. Let's stop there.
Okay.
And just thinking what case. So we have a CT head here, just 1 second. Okay, so we have a young patient. This is a 12-year-old. They present to the emergency department with headache and fever. So you can scroll.
Okay.
Oh, sorry, 1 second, 1 second. Okay, now scroll.
I've been provided with axial cut CT brain for child 12 years old. This with contrast media, the patient suffering from fever. The most striking thing I can see is that there is bilateral hyperdensity lesions detected within both cerebral hemispheres. And also I can see that within the right cerebral hemispheres there is a surrounding hypodensity suggesting that surrounds with edema. Low density suggesting edema. Just it's only with contrast. It's only with contrast. Okay. So just I want to have a look because this multiplicity could be inflammatory, could be infective cause or myths. Just I want to have a look. Okay.
Okay, so just summarize to me what you think is going
on. Okay, there is also enhancement of the there is enhancement of the internal meninges. So this could be inflammatory cause with
What's your
I-
differential diagnosis?
diagnosis for this, but if it's abscesses, if it's multiple abscesses, it will not take this homogeneous enhancement. It will take only marginal enhancement. The primary diagnosis, provisional diagnosis for this could be multiple MITs.
Okay. And what would you like to do next? So stop scrolling.
Okay.
Yeah, what would you like to do next?
Just I want to look I want to do MRI brain to see the signals of these lesions.
And what sequences would you like to look at?
I want to see the T1 axial and T2.
These don't seem to be loading. That's fine. Okay, for some reason these images aren't really loading. Is there anything else aside from an MRI brain, given your differential, is there anything else you'd like to look at?
This multiple rounded lesion, I don't know. It wouldn't be rather than multiple MITs. Just I want to know the signal in T1 and T2 to just know or only suggest the primary for this.
So how would you differentiate between metastasis and infection? Because those are your two differentials. Sorry, the MRI is not loading, so we'll just have to leave that. But tell me, how would you differentiate between an abscess and malignancy?
Okay, the abscess the abscess will be restricted diffusion. However, the MITs mostly no. The abscess will be slightly with a smooth wall, but the MITs could be with irregular wall. At the same time, most of them will have edema, but maybe the MITs will have more edema than the abscess.
Tell me, that's fine. Tell me about the restriction again. Sorry, I just missed it.
The restriction, the abscess will show restricted diffusion and low ADC. However, the MITs mostly it will not show like this.
Okay, fine. Let's go on to another case. Sorry, that one didn't work too well. We'll go on to our next case.
Okay.
So this is a patient who presents to the emergency department with low GCS.
Low what?
Low GCS. They're
Okay.
confused. Low GCS. You can scroll through it.
Okay. I've been provided with. Sorry.
Oh, sorry. Let me just zoom out. Hold on 1 second. Yeah, you can scroll now.
Okay. I've been provided with axial cuts CT brain for patients come with low Glasgow coma scale. Just I will scroll to the end and then I will comment. The most striking abnormality, I can see that there is a hyperdensity detected within the left upper frontal lobe, surrounded with rim of hypodensity, maybe edema. This density, this hyperdensity, I think just it's not causing mass effect on the ventricles. I couldn't see any evidence of hydrocephalus yet. At the same time, I am suspecting that it caused mild midline shift of the brain of the left hemisphere. I couldn't see any other abnormality within the brain.
Okay, so what would you like to do next?
I want to see this could be hemorrhage within the brain, could be a rupture aneurysm within this area. Just I want to check MRI signals for this lesion.
How would the MRI help you in this case?
Just I want to know if this is hemorrhage. Sorry, I want to check CT angio. Sorry.
Why do you want to do a CT angio?
I want to know if there is any rupture aneurysm detected within, because this area close to anterior cerebral, anterior communicating artery and anterior cerebral arteries, and there is no history of trauma. I want to check also the patient history, if there is any history of hypertension, just to know the cause of this hemorrhage.
Okay, fine. So here's the intracranial angiogram. Let's just zoom that up.
Okay.
Okay, you can scroll through.
Okay. I've been provided with CT angio for the same patient. Sorry, it's lagging. It's
Yeah, just give it. Actually, just stop scrolling. Give it a second.
okay.
Okay, now scroll.
Okay. Okay. Just I will go to the end and then here is the area of the abnormality. It's it is at the area of the anterior communicating artery. I can see that there is abnormal hyperdensity surrounding the anterior cerebral artery and anterior. I think it's anterior communicating artery. I couldn't see exactly aneurysm, but I can see that there is hyperdensity surrounding the vessel.
Point to me what you're referring to, sorry.
Okay, just 1 second. Here.
Yeah, so what do you think is going on?
Maybe there is leaking aneurysm or EVM. Maybe I don't know exactly. It's not clear aneurysm, but just
Where is if there is an aneurysm, where do you think it is? If you point to me on the screen.
here. Just 1 second. I couldn't detect it exactly. Just I feel that the contrast outside the blood vessels, but I don't know exactly what is the here. This is the area.
And you mentioned another diagnosis. So what supports that diagnosis?
Could be AVM.
And why do you think that?
Just because here it's look like for me AVM more than aneurysm. I don't know.
Is there anything else that would support that diagnosis on this on these images?
I don't know. Just
Scroll through to the top.
okay.
Other way, scroll other way.
Just 1 second.
Scroll to the vertex.
Okay.
And that's fine. Go back to the region of abnormality, please.
Okay. I can see both the vessels of the carotid appearing normal also, and both the middle cerebral artery appearing normal.
So I want you to stop there and scroll to the vertex of the skull.
Okay. I can see that this vessel reaching to the vertex, to the cortex, subclavian. Yes. I saw it.
Okay, so what does that suggest to you?
I will refer this patient for intervention radiology to make fixation for this AVM. Just only this, which
Okay, that's fine. Stop scrolling.
okay.
So just summarize the diagnosis and your next steps.
Okay, there is abnormal hemorrhage, abnormal density, which is high density within the area of the left upper frontal lobe. Mostly this is from abnormal AVM. After CT angiograph, we confirm that there is abnormal connection and there is no other abnormality, there is no other AVM. So we would refer this for the intervention radiology for fixation.
Okay, fine. So next case, a patient presents with lower back pain, okay? So this is the AP lumbar spine.
Okay. Lower back pain, okay. I've been provided with frontal X-ray of abdomen for a mature skeletally patient who complain from lower abdominal pain. I can see that the intestine appearing normal, the bowel loop appearing normal. I couldn't see evidence of pneumoperitoneum. This is the last cut of the.
Yeah, just leave it at that. You don't need to, that's all you need.
Okay. Just lower abdominal pain. Yes, the patient is
No, lower
complaining.
back pain.
Lower back pain. Okay. I would check for the spine. I can see the lumbar vertebra appearing normal. I couldn't see a mass abnormality. Just I would check the sacroiliac joint. I think the right sacroiliac joint appearing slightly fused.
Okay, just ignore that. Just focus on the lumbar spine. So is there anything else you'd like to look at?
In the lumbar spine, I would check for the vertebral bodies. It's appearing normal. Maybe I am not sure about the L5 vertebra for missing the oval the oval sign. I don't know. I'm not sure. It's really not clear too much for me. L5. I want to be sure that.
So what could you do to help you?
Sorry?
What would you like to do to help?
If there is a lateral view, also I would go for it. Okay. The lateral view for the lumbar spine, I think the L5 appeared abnormal in size and in height. The lumbar vertebra appearing slightly decreased in size and in height comparing to the previous, the upper lumbar vertebrae. However, the alignment of the lumbar vertebra appearing normal. Maybe the lumbar vertebra, the L5 show sclerosis. Really, it's not too much clear for me.
Okay. Or what would you like to do next?
I would go for MRI spine.
Okay, and at this point, what's your differential diagnosis?
I don't know exactly because I couldn't see well the lumbar vertebra, but if there is any sclerosis, I would be afraid sclerotic mets. Maybe sclerotic mets, maybe something other than this causing sclerosis within the vertebrae. Just I want to be sure about it from.
Let's have a look at MRI spine. What sequence would you like?
I want to see first the sagittal T1, the sagittal T1. Okay.
Yeah, you can scroll.
Okay. I've been provided with sagittal T1 for the lumbar spine, lumbosacral spine. I can see that there is isodense lesion occupying the lower sacral area. At the same time, I can see that the think it's S1 appearing abnormal, small in size and in height. I couldn't see the intervertebral disc space. This lesion extending to the spinal canal and also extending subligamentous anteriorly paravertebral. I just want to check it with T2 sagittal and post contrast.
Sorry, we don't have post contrast, but here's the
Okay.
sagittal T2.
Okay. The post contrast showed that L5 showed that I think the sacral vertebra taking contrast. The lesion that I saw within T1 also, the intervertebral disc extending between the sacral vertebrae and extending backward to the spinal canal. Yes, it's compressing the nerve root of the spinal cord, which may cause coda equina syndrome, and it would be emergency for to call the neurosurgeon to relieve this compression.
Okay, what would you like to look at to confirm if there's cauda equina compression?
Axial. Okay. Yes, it's here compressing the extending the just 1 second. It's extending here and compressing the nerve roots within this level.
Which levels to show me?
Just 1 second.
Show me the level.
1 second.
Okay, show me the level you think the compression is.
Here, I feel it's compressing here the nerve root.
Okay, fine. Thank you. We'll stop there just because we're getting very close to 30 minutes. Let's just quickly go through the case. Well done. It's very good. Just remind us that we started on case 7. I think just to begin with, what I really like that you do is when I say this patient presented with an out of hospital cardiac arrest, you repeat it back to me. I think that's a good thing to do in your Viva. It's just for all of those of you listening. So like the first thing you should do and get in the habit of doing is describe the study you're looking at. So this is a this is a CTPA or CT pulmonary angiogram of a patient who presents with an out of hospital cardiac arrest. So I really like that you did that. So that's good, and everyone should learn to do that. So on this study, you picked up on the key findings. So the first thing to say is there's no PE, because obviously a cause of cardiac arrest is a large pulmonary embolus. So there's no large pulmonary embolus. So right off the bat, we can say there's no PE. The next thing is the heart looks weird, right? So you've rightly picked up on this right ventricle is completely thickened. The right ventricle should never be thicker than the left. In fact, it should be much thinner. It should be almost paper thin. But if you look at this is all nodular and thickened. The interventricular septum is normal, and the cardiac chambers are normal in size. So it could still be a cardiomyopathy, but in cardiomyopathy, you might expect heart dilatation. The other weird thing is if you look at the right coronary is encased by the myocardium. That's not a normal finding. It's completely, entirely encased all the way down to the back of the heart. And this is where it becomes the PDA. The anatomy is not that important. It's more that the right coronary artery is completely encased by the muscle. Whereas if you look at here, this is the left main stem and this is the left anterior descending artery. You can see that it's just surrounded by fat. So that's normal. Whereas here, it's encased by thickened, what we think is hypertrophy myocardium, right? So people are welcome to say what they think this is in the chat. But then we had so what I wanted you to push at is that could this be like an underlying lesion within the heart, a malignancy within the heart? Could it be a lymphoma or some sort of sarcoma? I think it's less likely to be a cardiomyopathy. I can't think of any cardiomyopathy which presents with an isolated kind of right ventricular hypertrophy. I know you mentioned ARVH, but that presents with dilatation of the right ventricle and thinning of the right ventricular myocardium. So again, the MRI doesn't really add much. I just put it in there just to show you that it's all thickened. And then what you would have done at this point is you could do a FDG PET to confirm that there is an underlying lesion here. And as you can see, the right ventricle is hot. Okay, so it's all avid, and in particular, at the basal aspect of the right ventricle, it shouldn't be more avid than the left ventricle. In fact, in fact, it shouldn't really light up at all, but you can see there's all of this avidity here, and yeah, in the interventricular septum as well. So this is an underlying lesion. So this would need sampling and biopsy. And ultimately, this turned out to be a cardiac lymphoma, so primary lymphoma of the heart. And I think whenever the take-home message is whenever you see in radiology a vessel or a tubular structure encased by soft tissue, you need to think lymphoma. In the bowel, when you have bowel lymphoma, it encases, but it doesn't obstruct. So whenever you have encasement without blockage or obstruction, always think lymphoma. So that's one of the take-home messages of this case. Do you have any questions?
No.
Okay, good. Sorry, the next case didn't work too well, but we'll just quickly go over it. So yeah, I mean, I think that it was fairly straightforward that there was multiple ring enhancing lesions or multiple enhancing lesions with significant vasogenic edema. The differential would be metastasis or abscess. And the MRI would have helped, but basically, you said the right thing. So that an abscess would have a smooth wall, a smooth inner wall, whereas a metastasis would have a nodular or an irregular wall. The other thing is you can look at the diffusion restriction. So in this case, this didn't really restrict much. It had some mild restriction peripherally, but no central restriction. Whereas with the metastasis, you wouldn't expect that. You would expect the central restriction as well. And then we had this intracranial bleed. So what I would say is try and move things along. So once you've found like this is the diet that you've seen that there's a bleed here, right? So the way I would describe this is there's an intraparenchymal hemorrhage, which appears to be crossing the midline, centered upon predominantly the left frontal lobe with mass effect on the ventricles. You said there was no mass effect on the ventricles, I think, which is incorrect. It's squashing the frontal horns. Then you would say this is in the distribution of the anterior cerebral artery, so I would really need a intracerebral angiogram to elucidate this or to characterize this further. And then mention key negatives, as you did. There's no hydrocephalus, the basal cisterns and the foramen magnum are patent. There's no further intracranial hemorrhage. There's no gross soft tissue swelling to suggest trauma. So those are kind of the key negatives that you want to mention. But move it along quickly. Don't get stuck and keep describing things. But the key point there is you have to request, I want you to say, and you did, that you need a CT cerebral angiogram, which is completely the correct thing because of the distribution of the hemorrhage. Not all hemorrhages need an angiogram, but that hemorrhage was in the distribution of the anterior cerebral artery. And then as you follow the ACA, so it's here and here, these two dots, you can follow them, and then there's one here and one here. And then as you follow it to the vertex, it all of a sudden becomes this cluster of vessels. So you lose it, right? You lose it in this cluster of vessels, and one is particularly dilated and tortuous. And if you follow that dilated and tortuous vessel, you can follow it up to the vertex connecting to a dural venous sinus. So up here, yeah? Or a cortical vein, or basically it's going to connect to the dural venous sinus, yeah. So the point is, this is not an aneurysmal hemorrhage. This is not a traumatic hemorrhage, but this is related to this arteriovenous malformation. And then there's different types. You have an AVM, or could this be a dural arteriovenous fistula? But the point is, I wanted you to pick up on this is an abnormal cluster of vessels. And then you can give the differential of this could be an AVM or this could be a dural arteriovenous fistula. This needs referral to the neurointerventionalists or the neurovascular MDM for further management. And urgently, because obviously the patient has had an intracranial event. Okay, there's a few questions coming through. I will let me just get to the last case and then we'll come back to the questions. Actually, okay, let's just take the questions now for this case. So we said, how do you know this is not a hemorrhagic Met? Well, based on the non-con CT, the distribution is very much centered upon vessels, which really raises your suspicion that this is a vascular issue, not a Met. You're right, this could be a hemorrhagic Met. And the only way to really discern that is to do an intracranial angio. And if that's normal, you'd end up doing an MRI and follow-up imaging to see how the lesion evolves. The problem is once you've got hemorrhage superimposed on a lesion, the MRI is very difficult to characterize. It's actually quite difficult to tell if there's an underlying lesion. So the point is here is that this hemorrhage is centered upon a vascular territory, and that's why you need to do the angiogram. Once you've done the angiogram, you know that this is obviously vascular and it's not metastasis. And how you differentiate between METs and abscess. So METs are the most common intracranial lesion, but you can also get abscesses. Abscesses have a smooth inner wall. Okay, they have a smooth inner wall, whereas METs tend to be nodular in their wall. And obviously you'd expect to have a primary somewhere else. So that's the other way. And think about the clinical history as well. I think that's one thing you guys need to ask about more is the blood. So what are the inflammatory markers? Because if I tell you the inflammatory markers are raised, it's going to be an abscess. And then the other thing is you can look at the diffusion restriction pattern. I never really found this completely reliable, but in that case that we saw, if we had the MRI, you would see that there was no central diffusion restriction. So centrally, it did not restrict. Whereas for a metastasis, you would expect it to be restricting centrally. And then this is the final case that we looked at. So I think you were getting stuck on the AP. So if you're stuck, just always ask for another view. Don't be scared to ask the examiner, is there any alternative views? And then here you can see that there's end plate sclerosis, loss of that L5 vertebral body height. And you need to think that is this degenerative or is this infective? And you can even get the impression there's actually quite significant end plate irregularity. So at this point, I would ask the examiner, is it possible to know what the inflammatory markers are as an example, and then go from there. On the MRI, I would not look at the SAG-T1 first. I would personally look at the SAG-T2 first if you're particularly if you're limited for time, or the SAG-STIR, because the pathology will just light up. But yeah, there's L5S1 end plate erosion. There's high intensity centered upon the disc space, which extends into the adjacent vertebra. There's further high intensity in the paraspinal musculature and extending into the paravertebral space. I've got this one. I've got it. Thank you. And then I would say that I would like to look at the axial slices. And you can see that there's cauda-equina compression at this level. Okay. So you can see nerve roots and you can see CSF, and then you lose the nerve root, you lose the CSF signal. Okay. So there's cauda-equina compression at this level. I think you thought it was lower down in the sacrum down here somewhere. But yeah. And here you can see the T2 signal. So say that again.
I saw it in sagittal.
Okay, yeah, fine. But when I was asking you on the axials, I think you localized it to the wrong spot. So this is the region where it compresses.
Okay.
And then there's extension of the infective process into the paraspinal musculature, as we saw. Yeah, so this is a case of spondylodiscitis with paraspinal abscess and likely paravertebral abscess as well with cauda-equina compression. This needs urgent neurosurgical intervention. Good. Just looking through the questions. Can we think of venous infarct? The same case? No, I wouldn't suggest venous infarct. You can get venous infarct leading to hemorrhage, but I mean, there's, the angiogram is very clear in that there is a nidus of vessels, and it's centered upon the ACA on the non-con. So I wouldn't have that right up there on my differential. Okay, cool. Thank you, candidate 3. Do you have any questions before we move on?
No, sir. Thank you.
Okay, candidate 4. Let's finish off.
Yes, sir.
Let's see. Okay, I don't think we've done much MSK, so let's move on to that. Okay, candidate 4. So this is bilateral feet X-ray in a 27-year-old. Presents with foot pain.
This is the frontal radiograph of bilateral feet of a 27-year-old person with pain. There is evidence of multiple loosened areas involving almost all the bones of the both feet, which is showing, which is patchy in distribution. There is mm, mm, there is no evidence of significant soft tissue component. There is especially it is affecting the metacarpophalangeal joint as well as the carpometacarpal joints. Also the intercarpal, tarso-metatarsal and metatarsophalangeal joints and the interphalangeal joints. So I would like to know whether the patient has any history of any neuropathic diseases, because that can cause this type of erosive changes, but I'm not seeing any gross destructive changes which will be seen in that neuropathic joints. The possibility is some infection, but usually infections are associated with a significant soft tissue swelling and more destructive changes. Another possibility is autonomic sympathetic that due to some gross immobilization, there can be Sudeck dystrophy. That I will also like to know whether the patient has any history of immobilization for a long time after some trauma or something.
Okay, so just give me your most likely differentials here.
Sir, pardon?
Give me your most likely differentials here.
Slightly?
Your most likely, what do you think is most likely going on?
So some erosive process, but I'm not seeing any marginal erosions or any significant, but it is symmetrical. The disease is symmetrical, and there is a periarticular osteopenia. So and tarsal involvement specifically. So there is a possibility of rheumatoid arthritis because there is some changes in the bone. There is some bone deformity also. So one possibility is a rheumatoid arthritis. So I would like to know whether there is any elevation of rheumatoid factor in this case. I will call it the clinical.
What would you like to do next?
I will call it the clinical history. Will ask for the rheumatoid factor. If it is not already done, I will like to I'll ask to order for a rheumatoid factor survey.
And the rheumatoid screen is completely normal.
Rheumatoid is normal. Okay, then another possibility is which arthropathy, inflammatory arthropathy involving the lower limb, specifically like some any Retter's disease or some.
What do you think of the joints? What do you think of the joint spaces?
Joint spaces are not it is not affected.
Okay, so you told me the joint spaces are not affected. There's no erosion. So do you think this
periarticular osteopenia is there? But
yeah. So what else would you like to do? What would you like to do next?
I would like to I will proceed with an MRI scan.
Okay,
Like to
fine.
proceed.
So here's we've done MRI of both feet, but just for purposes of simplicity, I'm going to show you the left foot because the changes, the findings are the same. So you can request to take control of my screen.
How can I request?
To be honest, I'm not actually sure. I think if you go on the bar at the bottom,
Yeah.
it should offer you an
Okay.
option.
How to put the request in this? Can you tell me?
I think if you go to the bar at the bottom, if I'm not mistaken, you just select request control.
Yeah, okay, participation. First tools.
Can one of the candidates tell candidate 4 how to ask for mouse?
Yes, maybe with candidate 3, because we did it with candidate 3. If you're able to tell us how you requested control.
The
Okay.
options. Okay.
No, not to worry. Like, I'll just scroll through it, and and that's fine.
But in future, for all of you who volunteer, please make sure that you do this. You should know this before volunteering for a virus.
Okay. Okay.
Not to worry. That's fine. What sequence would you like to look at?
I would like to see PD fat set.
Okay, so we've got a coronal or an axial. Which one would you like to look at? Candidate 4. Would you like the axial or the coronal PD fat set?
Axial first.
Sorry.
Axial MRI section shows there is no significant edema in the visualized metatarsal bones, but the muscles there is no evidence of significant joint effusion.
Would you like to look at any of the other sequences?
This I like to see the T2 weighted sequences.
Oh, we only got PD. We haven't got T2 weighted sequences. We've got PD fat set.
PD fat set. Okay.
And I've
then
got
T1 weighted sequence.
Okay, fine.
The T1 weighted sequence, the bones appear grossly. It shows normal signal intensity of the bones. Okay. So this appears to be an inflammatory arthritis anyway. I would like to know whether the possibilities into reactive arthritis, Reiter's disease.
Why do you think this is an arthritis? Why do you think this is an arthritis?
Because of the periarticular involvement, specific periarticular involvement more.
And on the MRI, why do you think this is an arthritis?
MRI, I'm not seeing any specific supportive factor.
Okay, that's fine. So you're not seeing anything specifically. So let's just have a quick look at the stir.
There is no gross destruction or any significance of tissue component.
Okay, fine.
There is no history of immobilization.
There is, yeah.
There is any gross history of immobilization for the leg, for the foot.
Yes, there is.
So it could be that sympathetic sudic dystrophy that can present like a lucencies, patchy lucencies.
And what could help you make the diagnosis?
Because I'm not seeing any other infective or significant infective changes or arthritic changes.
Sure. But what
If
other
there is
imaging
any
could you do to help you make the diagnosis?
from the X-ray, I felt like that. That is
Is that
mainly clinical history. That actually should be correlated with the clinical history. The clinical examination will more
that's
than.
fine. Let's move on to the next case. This is a young gentleman who presents with knee pain after he had a fall.
Knee pain after
Falling.
fall. Okay. This is the frontal radiograph of the right knee joint of a young patient with a history of fall. So there is the first thing I notice is a small chip of bone at the lateral aspect of the lateral tibial plateau, suggestive of Seagon's fracture. So the Seagon's fracture is usually associated with the ACL tear. So I will inform the findings to the referring physician and will advise to do MRI scan also to rule out the associated ACL tear for this patient.
Okay, here's an MRI knee. What sequence would you like to look at?
ACL tear, I would like to see a PD fat sat sequence.
Say that again, sorry. What fat sat? Which?
PD, the sagittal sequence or oblique or on.
Okay, so we've got a sag PD fat sat here.
This is
Sorry, the windowing is just a bit weird, but yeah. Please continue.
this is a sagittal PD fat sat images. I'm looking for it can be associated with the okay. I'm not seeing a normal anterior cruciate ligament in the expected location, and with the significant edematous changes in the upper aspect of the anterior cruciate ligament, suggesting a high-grade tear of the anterior cruciate ligament, which is well associated with the Seagon's fracture. Medial meniscal injury is also another more ACL tear is more commonly associated with medial meniscal tear. The lateral meniscus appear grossly normal. There is double PCL, doubt of double PCL sign. Medial meniscus appear. Can you see once more? There is evidence of a tear of the there is a tear of the medial meniscus, posterior horn of the medial meniscus. Some vertical tear is seen. So there is anterior cruciate ligament injury, posterior horn of medial meniscal tear, and the Seagon's fracture.
Would you like to look at any of these or sequences?
Sir, pardon?
Would you like to look at any of the other sequences or views?
I'm looking. There is evidence of bony contusion. There is a kissing bony contusion, which is also suggestive of ACL injury. And I would also like to see the T1 weighted images to look for any other bony fracture associated with trauma. Is the
Okay, that's fine. There's no fracture. There's no gross fracture
no
aside from what we
gross
saw in the
fracture. First,
X-ray.
I will check the
what
PD fat sat image just to look for any edema, and I will look carefully on that region to look for fracture in the T1 weighted images.
Okay, fine. Here's a coronal. Let me know if you notice anything else.
I would like to see. There's a doubt of a double PCL sign. I would like to see that also. If there is double PCL sign, there is a bucket handle.
Okay, on the side. So show me where are you seeing a double PCL? You're telling me there's a double PCL sign.
I'm down. Just check. Yeah, no definite. Okay, solely ACL. Okay.
Is there a double PCL or not?
No PCL.
Okay, fine.
PCL appears no.
So what else do you notice on the coronal?
So I will inform the findings to the referring physician and will refer the patient to the orthopedic surgeon for further management.
Sure. Is there
Patient
anything
will
else? Anything else you'd like to look at?
I will also look at the other ligaments. Of course, I will look for in injury. I will look all the other ligaments in with
Yeah.
the
So
corners,
look at them.
posterior
They're
and
here. So
posterior,
look at the other
and the
ligaments.
medial and medial collateral ligament appears. There is evidence of edema surrounding the medial collateral ligament, suggesting grade 1 injury. There is no triangle rupture of the ligament. Lateral collateral ligaments, as well as the corners, posterior and posterolateral and posteromedial corners also will check.
Okay, that's fine. And how do you describe the pattern of bone contusion?
Describe bone.
How do you
Bone
describe the
contusion.
pattern of bone contusion?
A bone contusion, ACL, they are usually associated with the kissing bone contusion, like that posterolateral aspect of the tibial plate, as well as the middle aspect of the femoral condyle will be showing contusions in ACL. ACL most of the time in
Okay,
ACL.
that's fine. Let's move on to the next case. So this is a abdominal ultrasound for a patient who presents with vague abdominal pain. So I'll scroll through the images for you. Can you just check? I think, did you request control? Because I think
I didn't have a post to remove.
that's fine. Okay, that's fine. Don't worry. I'll just
Not
scroll
able
through.
to.
So this is the liver.
1 second. Yes, I could see. Request, I have sent request for control.
Okay, try
Send,
scrolling.
send me to enable AI companion. Is it like that? Request, I sent request for that.
Can you scroll or not?
I will try. So. Not able to scroll.
Okay, that's fine. Don't worry. Don't worry. Okay. So look, this is an abdominal ultrasound. Just let me know what you see. Focus on the liver, please.
This is the ultrasound scan for patient who present with abdominal pain. Sir?
Yeah.
Okay. There is a there appears dilated intrahepatic biliary radicals involving bilateral both lobes of the liver. I'm looking for the cause of the biliary obstruction. Portal venous flow appears normal with a forward flow. The liver
Just look at this image for me. So what do you think is going on?
There is some increased flow in the portal vein, maybe like some
Put all of this together, so what you saw earlier.
It can be some transformation of the portal vein, like a cavernous transformation of the portal vein.
Okay, or yeah,
That can
any other differential?
There can be multiple collaterals due to obstruction of the portal vein due to some cause like portal cirrhosis, but I'm not seeing any evidence of cirrhosis in the liver.
Okay, that's fine. Let's have a look at this CT, which they go on to have. So I want you to focus on the abdomen and pelvis first, okay, and on what you saw on the abdominal ultrasound. It's just loading. Give it a second.
These are the contrast enhanced. Yes. CT scan of the abdomen, chest, neck, chest and abdomen. There is evidence of the liver shows evidence of multiple tortuous and dilated flow of channels, vascular channels. The hepatic artery appears dilated, common hepatic artery. The veins appear, hepatic veins appear normal. There is liver shows altered attenuation. The splenic artery all the arteries appear dilated, closely dilated. So I'm suspecting some anyway there is a vascular abnormality in the liver. It could be some vascular diseases like a hemorrhagic HHT, hereditary hemorrhagic telangiectasia. One possibility is that other thing can be some arteriovenous, but this is a diffuse involvement. So my first diagnosis is HHT.
Okay, so
I
if
would
you say
like
HHT, what else would you look for?
Sir?
What else would you like to look for on this scan?
So it is associated with aneurysms in the brain also. So I would like to know the history of the patient, whether the patient has any symptoms, cranial neurological symptoms.
Okay,
Otherwise,
that's fine. They don't. But is there anything else on this scan you'd like to look at? We have a chest, abdomen, pelvis here. Is there anything else you'd like to look at?
there is multiple collateral channels in the splenic hilum, and also the spleen appears normal in size. Otherwise, I'm not seeing any
Okay,
other.
so let's look at the thorax and tell me what you're finding.
Thorax, there can be multiple aneurysms.
Just look at the thorax, please, and let me know what you see.
Multiple, there is increased vascularity. It's noted in the lungs also, can be due to multiple pulmonary arterial malformations, which is associated with the Osler-Weber syndrome.
So what are you referring to?
This patient is referred to the cardiovascular surgeon and
No,
interventional radiologist.
what can you see? What are your findings in the lungs? I didn't quite catch it.
There is increased the size of the vessels, pulmonary vessels, and also there is some nodular lesions in bilateral lung fields. With the vessels going into the lesion, suggestive of pulmonary arteriovenous malformation.
Okay, so summarize what you think is going on.
So in a young patient with abdominal pain, the ultrasound of the liver shows multiple dilated vascular channels involving the porta hepatis, with the increased flow and multiple dilated vessels in both lobes of the liver. And on CT scan, it is showing multiple anomalous vascular channels scattered in the liver with the dilated other arteries are also suggestive of vascular pathology, and the most common cause of this pathology with the diffuse involvement is HHT or Osler-Weber syndrome. And this patient needs to be and in the chest also there are multiple pulmonary arteriovenous malformations. So and the brain also has to be screened for any malformations of the vessels, and the patient needs to be referred to
Where's the most common place they get malformations?
in the brain, or
Where is
in the
the
liver,
most common? Where is the most common place?
in the lungs and the liver.
Okay, that's fine. Let's stop there. Let's go through the cases. So we started off. I think this is probably the most difficult case in the whole packet that we saw today. But I actually think like you actually did really well on all your cases. I was pushing you to just be a bit quicker just because I wanted to get through some more things, but you did really well in tackling this, actually. I think you said there was periarticular osteopenia, which is absolutely correct. So this is a 28-year-old, and I think you mentioned quite early on that this could be pseudex atrophy. I think all your differentials are reasonable. You mentioned, is there an underlying neuropathy? You mentioned, so people always when I present this case, they say arthritis and because of the periarticular osteopenia. But the problem is that the joints are actually preserved, right? So the joint spaces are completely normal. There's no erosions. There is periarticular osteopenia, but it doesn't fit with an arthritis. And what I think in this instance, if you're stuck, you can say like, do we have any previous imaging to compare to? Or you can say, can I have a look at imaging of any of the other parts of the body, like the hands? Because we have, if you'd asked me, I would have presented you a hand X-ray. It's very unusual to get an isolated inflammatory arthropathy of the feet. That's not common. So you can see that the hands are completely normal. The feet are abnormal. And if you'd asked me for old imaging, you could see that the feet were previously normal. So I think in this, if you're presented with this case, you went down some really good differentials. There's periarticular osteopenia. The joint spaces are preserved, so I suspect this is unlikely to be an inflammatory arthropathy. My differentials for something like this could be an underlying metabolic disorder, or alternatively, if there's been a history of trauma or immobilization, this could be pseudex atrophy. I would like to do an MRI foot to help guide me further. I'd also like to look at any previous imaging or any imaging of the remaining appendicular skeleton. And then the MRI basically doesn't help, right? It's fairly normal. And then in that sense, it helps us because the bone marrow returns a normal signal. Again, the joint spaces look preserved. On the STIR, there's no kind of high signal to suggest like an inflammatory condition. And then I told you that there was a history of immobilization, and you did very well to say that this is pseudex atrophy, so that was very good. The test that you can do to help confirm it is a bone scan. Okay, so you can do a dual phase bone scan. I won't go into that now, but you can you see periarticular uptake. And that's got high sensitivity for pseudex atrophy, and that's how you can help diagnose this condition. The abnormal thing about this case, it's an atypical case, and often they'll show you atypical cases in the exams. It's bilateral. Pseudex atrophy is usually unilateral because obviously it happens after trauma, and you don't normally have trauma to both feet, right? Normally one foot, like the patient fell over and broke their ankle, for example. So this is an unusual case. Do you have any questions? No, but I think honestly, you did very, very well on that scan. Probably one of the best that I've ever shown that case to, because people don't usually pick up on pseudex atrophy. So this is good. I think this is kind of one of your more typical cases. This is a second fracture, tiny little fleck there. And what I liked is that you went on to say that this is associated with an ACL injury. Don't wait for me to ask you. So you did that. You said there's a fleck of bone next to the lateral tibial plateau. This is a second fracture. It's in keeping with an association of ACL injury. I would like an MRI. And then the MRI, I think you spent a bit long, like kind of going on the sagittal. You just need to, like I said, just move through quickly. If there's something that you've missed, I will guide you back to it. But I think it's getting stuck on a particular sequence. It can be a bit tedious. So just try and move things along quickly. You already know the diagnosis once you've looked at the X-ray. So there's the ACL fibers aren't readily seen. And obviously we look at that in other views as well. Don't just look at the sagittal, but there's a ACL tear, the PCL is intact. Go through it systematically. So, okay, first look at the cruciate ligaments. Okay, there's an ACL tear. Now I'm going to look at the bone marrow signal. There's high signal within the posterior lateral tibial plateau and within the lateral femoral condyle, if I can find it. So it's mainly in the posterior lateral tibial plateau here, and then in the lateral femoral condyle here. Yeah, in the terminal sulcus. So there's a name for that. Do you know what it is? Or anyone in the chat? Yeah, so pivot shift. Yeah, so that's important because this is like one of your common, sorry, it's windowed really badly, but anyways, yeah, that's a common injury pattern for ACL injuries. So it's a pivot shift pattern of bone contusions with an ACL injury. And what I like though is you did say, okay, you've seen an ACL injury, you have to look at the medial compartment. So you looked at the medial meniscus and you're on it, you look at the MCL. ACL injuries come in tandem with pivot shift, and you want to look at the MCL and the medial meniscus. They all kind of come together. And then if you look at the medial meniscus, there's a tiny tear. I mean, I'd forgive you for missing it, but it's in the posterior horn here, there's a small tear, okay? And then I wanted you to look at the medial compartment, which I had to push you, the medial collateral ligament, which I had to push you a bit for, but the medial collateral ligament there has got high signal around it and it's thickened, so that's in keeping with an MCL sprain. I personally wouldn't grade it because I always forget gradings, so I would just if you feel like you can remember it, that's fine. And the way you grade it is it's to do with the high signal, if it's on one side or both sides, or if there's a complete break in the MCL, and that's obviously a tear. But this is in essence pivot shift, bone contusion pattern, ACL injury, second fracture, medial meniscal tear. Okay. And then you would suggest this patient needs to be referred to orthopedics because they will need surgical correction of the ACL injury. So if you look in the intercondylar notch, you should see ACL fibers traversing that, but you can't see them. It's just obliterated by high signal. So that was good. This one, so I think you went down the biliary dilatation route because you saw dilated structures within the liver, but what I was trying to show you is that they're vascular. So they're all vascular, okay? So these are all dilated vascular structures, and I think cavernous transformation is reasonable as a reasonable differential. Obviously, you'd expect that to be around the hepatic hilum, but I still think it's a reasonable differential. The other differential would be an AVM, and then once you see the actual CT, it gives the diagnosis to you. Sorry, we'll just let this load. Give it a second. So the key thing is, I think you said something about the splenic artery. The splenic artery is fine. It's just the hepatic artery. So the hepatic artery comes out here. This is the splenic artery here, right? It's normal in caliber. If you follow it around, it's actually normal and tortuous like it normally is. But the splenic vasculature is normal. The hepatic vasculature is grossly dilated, tortuous, with multiple collaterals scattered throughout predominantly the kind of central portions of the liver. So these are hepatic AVMs. You should never see hepatic arteries that dilated. Okay. And then what I was trying to push you towards is like when I was saying, where else would you look? You can look in the thorax and they've got pulmonary AVMs here. So if you look at these brightly enhancing structures, you can see two vessels coming off. One of the vessels, if you follow it back, so one of the vessels comes in here into the pulmonary vein. Okay, and another one here comes off the pulmonary artery. So we've got one here coming off the vein, one here coming off the artery. And if you follow them down, so here and here, hopefully those are the right vessels. Oh, sorry, it's these two here. But basically, you can follow the vessels back to the pulmonary artery and into the pulmonary vein. And there's another one here where it's a bit more obvious. So you've got one vessel here and one vessel here, which connect back to the pulmonary vein and to the pulmonary artery. So these are pulmonary AVMs. You said they were bilateral, they're actually only unilateral. But yeah, you've got the syndrome, which is very good. So they've got hepatic and pulmonary AVMs. Putting that together, that's Osler-Weber-Rendu or hereditary hemorrhagic telangiectasia. The most common site of AVMs is the nose. Okay, so they present with nosebleeds. So that's what I was trying to push you towards. They also get cerebral AVMs. They can get AVMs in their GI tract as well. So you can look for any points of GI bleeding. Good. Do you have any questions about that?
So thank you.
Okay. And just looking at questions in the case, so in the chat, so hepatic AVMs, you can't really tell. It's harder to see the connection between the arteries and the veins in the liver. But what gives it away is that you shouldn't ever have a tortuous and dilated hepatic artery like this. Normally, it's very slim. So if you think about looking at CT abdomen pelvis, normally, sometimes it's actually quite difficult to follow. That's how slim it is. But this is grossly dilated and tortuous, and that's what suggests that this patient has AVMs. Good. Any other questions? Diagnosis of the foot case. That was Sudeck atrophy, also known as complex regional pain syndrome. Okay, I think that ends it there. So candidate 4, that was very good. Sorry if I was pushing you a bit and trying to rush you along, but you did very well, and all of the other candidates did very well as well. And I think we all have some points to go away and work on, hopefully. But Yeah, Dr. Khan, I'll hand back over to you if that's okay.
Absolutely brilliant cases, beautiful cases. Really enjoyed that.
Thank you.
Shoaib. The last one, the ultrasound, was super special.
Yeah.
To see it on ultrasound, that was very
Good.
nice. And just for the audience, many ultrasounds are coming, and not just in part one in anatomy, but in the main viva also. So beware of that. Shoaib, anything else? Anything else you want to?
That's it from me. Just in terms of general feedback to everyone, I think we always forget is when you're starting, say the name of the, this is the CT thorax post contrast in a patient with chest pain, repeat it back to the examiner, go through things systematically. Don't waffle too much, just get through the key points and try and move the viva along and direct the viva yourself. Don't wait for the examiner to ask you what's the diagnosis. I think those are the key points that I would feed back to everyone. But otherwise, very good.
Thank you very much. And candidates were also very good. So well done to all of you.